Hello, my name is Victoria von Saucken, and I'm from Sugar Falls High School. This summer, I had the wonderful opportunity of being a Cleveland Clinic science intern and got the chance to work under Dr. Luciano and Dr. Dombrowski in the section of pediatric and congenital neurological surgery in the Neurological Institute at the Cleveland Clinic. And our project is a retrospective study of patients being evaluated for idiopathic normal pressure hydrocephalus, or simply INPH. Now let's start with some introductory questions. What is normal pressure hydrocephalus and idiopathic NPH? What are the clinical symptoms of a typical atypical patient? What specific radiological indicators are used to help diagnose NPH? And how does the combination of radiological findings and medical history improve the understanding? Now, normal pressure hydrocephalus, or NPH, is a type of communicating non-obstructive hydrocephalus, which means that the cerebrospinal fluid, or CSF fluid, that is created in the ventricles cannot be absorbed into the subarachnoid system. Idiopathic simply means that we do not know the cause of this. Dr. Solomon Hakim first introduced NPH in 1965, and this condition is present in adults over the ages of 60 years old. In 2005, formal guidelines were published for how to diagnose NPH patients in the Journal of Neurosurgery. Now, hydrocephalus, hydro meaning water, and cephalus meaning head, is often referred to as having water in the brain. And this is because with this condition, there's an increase in ventricular volume, or enlargement of ventricles, which is called ventricular megaly. If we look at the image to the right, this is a hydrocephalic brain, and we note the enlargement of the ventricles compared to the healthy brain to the left. Now, there are a triad of clinical symptoms associated with NPH. The primary symptom is gait and balance disturbance, followed by memory and cognitive deficits and urinary incontinence. What makes these patients atypical is the fact that they do not need to possess all three clinical symptoms. Sometimes patients only possess one symptom, which makes it even harder to diagnose with NPH. There's only one universal radiological indicator, and that's the Evans ratio and index, commonly referred to as the EI, which is a ratio between the width of the lateral ventricles over the width of the brain. And when the EI is greater than 0.3, that means that ventricular megaly, or the enlargement of ventricles, is present. And in order to take these measurements, you need an axial CT and MRI at the level of the foramen of Monroe. Now, there are some secondary and often speculated radiological indicators for NPH, because what we need to consider here is that each scientific community around the world has different methods for how they diagnose NPH. The first being severe medial temporal lobe atrophy, which in this image to the right we see is a diminished size of the gyri, as well as an increased size of the temporal lobe region, which is located right here. And then there's also white matter hyperintensities, often referred to as WMH, which is pointed out by the green arrows that surrounds the ventricles. And then high convexity and high midline areas, which was introduced by a Japanese study. And as we can see in the image, at the high midline area, there's a decreased amount of space for the cerebrospinal fluid to flow. Now, there are some confounding variables of NPH, the first being age. The fact is that the NPH population is dealing with the elderly, and the elderly population, 10% of them have urinary incontinence and memory or cognitive deficits, which are two of the three clinical symptoms. There are also neurological conditions such as dementia, motor impairment like Parkinson's disease, and depression to consider, as well as non-neurological conditions, cardiovascular conditions, orthopedic, and polypharmacy. When patients come to us to the clinic, they have multiple diseases of X, Y, and Z, as well as having some of the clinical symptoms. And we need to consider this and diagnose patients individually because this population is very diverse. Now, the NPH improvement score is an algorithm based on the gait test, neuropsychological test, and self-report. And this is completed pre- and post-testing of cerebrospinal fluid removal, which is done at the lumbar region to find good candidates of cerebrospinal fluid shunting, which is the ultimate treatment of NPH. Now, an NPH score of 0 to 2 means that there's little to no improvement, with the CSF removal, but an MPH score of 3 to 6 means there is significant improvement. And for clarification, this is specific to the Cleveland Clinic and was developed by Dr. Luciano. Now, our hypothesis was that patients being evaluated for IMPH will have infrequent comorbidity with memory and motor impairments, and that the majority of patients will also have radiological findings of white matter hyperintensities. Thirdly, the presence of specific radiological findings, such as WMH, CSF flow obstruction, temporal lobe atrophy, high and tight, infarcts, will be inversely correlated to the MPH improvement score. For methodology, our study was Cleveland Clinic Institutional Review Board and HIPAA approved. It consisted of going through 143 consecutive and digital patient records from 2006 to 2011. These patients presented at the Aging Brain Clinic and the Hydrocephalus Clinic, which is led by Dr. Luciano at the Cleveland Clinic. And it consisted of doing a medical chart and radiological review. The chart review characterized presenting symptoms of these patients. Data collected includes cognitive impairments and duration, gait deficits and duration, pre-existing conditions that could explain their symptoms, such as Alzheimer's disease, and the outcome was CSF removal, or the MPH improvement score. The imaging review, we viewed and analyzed using specific software, such as Single Image Viewer or Magic View. And this is done using CT and MRI scans, which for the MRI scans, we utilized all planes, sagittal, coronal, and axial, as well as MRI Sydney flow studies when available. And there are numerous inter and intra-radar reliability checks. The following are the radiological observations that we observed. Evans index and ratio, obstruction of cerebral spinal fluid flow, severe medial temporal lobe atrophy, white matter hyperintensities, high convexity and high midline areas, and infarcts, including cortical, non-cortical, cerebellar, and brainstem. Now this is one of the radiological findings that we noted, obstruction of cerebral spinal fluid flow. At the top left corner, we see a normal MRI Sydney flow study, which a Sydney flow study marks a detailed analysis of the CSF hydrodynamics of the brain, or the flow of the cerebral spinal fluid. To the left here, we have a sagittal view of a normal brain for reference of the brain structures, as well as to the right is an MRI Sydney flow, and what is focused on is the obstruction, which happens to be in the cerebral aqueduct going from the third to fourth ventricle. Now, temporal lobe atrophy, to the right, as explained earlier, we see a diminished size of the gyri compared to a brain with no atrophy, as well as an increased amount of CSF space in the temporal lobe region compared to a brain with no atrophy present. For white matter hyperintensities, going from mild to severe, we have small caps, large caps, irregular, which is all over the place, and extensive, which goes from the frontal to the occipital ventricles. And then high convexity, high midline areas, oftenly referred to as high and tight, is when there's a diminished space between the two hemispheres. And as we can see with a brain with no high and tight, there is an increased space between these two hemispheres at the high midline area. And cortical infarcts we also observed, and these are three different views. We see a difference in the blood, white blood versus a darker gray. The white blood is fresh blood while the darker gray is decomposing. And we can compare the frontal versus occipital regions in the sagittal view, as well as in the axial to find the infarct. Now, results for clarification are expressed as a percentage of total data, clinical and radiological available. First, we analyzed the chart review, or the presenting symptoms of these patients, and found that gait disturbance was present only in 22.4% of patients. Out of 143 patients, only 2.8% had cognitive disturbance only, and the majority, approximately 75%, had both gait and cognitive disturbances. For comorbidity, we found that Parkinson's disease was the most prevalent, with 12% out of 143 patients, with dementia and depression being approximately 6% individually. For secondary radiological indicators, we found that temporal lobe atrophy was present approximately 16%, or 9 out of 55 patients. High and tight was present about approximately 4%, or 3 out of 71. CSF obstruction was 14%, or 5 out of 35 patients. Cortical infarcts was present for 23%, or 16 out of 74 patients. and non-cortical infarcts was present for approximately 7% or 5 out of 75 patients. For white matter hyperintensities, we found that 71% or 52 out of 73 patients had white matter hyperintensities compared to only 29% without. And then we focused on the different types and found that small large caps or mild white matter hyperintensities were the most prevalent compared to severe or irregular and extensive white matter hyperintensities. And then we compared the clinical outcome versus white matter hyperintensities and focused on which patients had the greatest significant improvement. We were hoping to find a trend, but what we discovered was that 61% of patients with no white matter hyperintensities had significant improvement, versus when we subdivided white matter hyperintensities into different types, we found that 40% of patients with small caps had significant improvement, 25% of patients with large caps had significant improvement, and then for irregular and extensive, it was 70 and 50% respectively. As for radiological findings versus clinical improvement, we found that patients with white matter hyperintensities had a 42% in clinical improvement. Patients with temporal lobe atrophy had 56% clinical improvement. Patients with CSF flow obstruction, 100%, so 4 out of 4 patients. Patients with high and tight had 67% clinical improvement, and clinical improvement is the MPH improvement score between the range of 3 to 6. And for cortical infarcts, we found that 50% of patients had clinical improvement. Now for conclusions, we found overall that 23 out of 100 patients had a presence of comorbidity, which shows that it is infrequent for the MPH population. So approximately 71% of patients had white matter hyperintensities, so we found that this is highly frequent with these type of patients. The presence of white matter hyperintensities is related to the clinical improvement, as we found, since patients with no white matter hyperintensities showed the greatest improvement with CSF removal compared to patients with any type of white matter hyperintensities. And then we found that MPH patients exhibit a wide variety of clinical symptoms and radiological findings that often makes definitive diagnosis difficult. The purpose of this study was to be a descriptive study and finding more trends with these MPH patients to make diagnosis even easier. So the clinical symptoms and radiological findings that we found, such as a low frequency of comorbidity and a high frequency of white matter hyperintensities in these patients, may be useful in predicting improvement with treatment, which is cerebrospinal fluid removal. Recommendations: that we document pre-existing cardiovascular diseases and medication. For the imaging review, we should measure white matter volume because I feel that there is a connection between white matter and MPH, as well as document cerebral blood flow in hydrodynamic studies. Here are my references that I used to write my background information. And acknowledgements, most important part. A special thank you to Dr. Luciano and Dr. Dombrowski, as well as the clinical and experimental team in the pediatric and congenital neurological surgery section, including the undergraduates, for taking time out of their schedules to teach me from anything from p-values to APA format to even lessons on life. And then a special thank you to Ms. Strickland, Ms. Starling, and the Office of Civic Education Initiatives for choosing me for such a wonderful and life-changing internship.